Hello and welcome everyone. Today we will do a brief summary of the papers which were published in the last month, that is November 2023. The first study is alcohol-based decontamination of gloved hands. It was a mixed method, multicentric three-arm RCT in adult and pediatric medical surgical intermediate and intensive care units of 4 hospitals. Here the healthcare providers who excluded those working with Clostridium difficile patients and dietary or environmental services personnel. In this, the healthcare professionals were divided into 3 groups, that is intervention, where the alcohol was applied directly to the gloved hands, gold standard, that is removing the glove and performing hand hygiene, and then using new gloves, and the usual care, that is a healthcare professional who was observed but not instructed in hand hygiene. The gloved hands sampled via direct imprint, comparison of bacterial presence between the arms was done. This is a qualitative analysis of the study. Now, in this, the results show that intervention arm versus the gold standard, that is gloves with alcohol, had 82% presence of bacteria versus 67% in gold standard, but reduced hand hygiene time, that is only 14%, while it took 30 seconds in the gold standard. In the intervention and usual, the reduction in the bacteria presence compared to the usual care was 76%, while it was 98% in the usual care, where the presence of bacteria was more. So in conclusion, the directly applied alcohol on the gloves reduces contamination compared to the usual care, but it is less effective than gold standard. But it does offer a advantage in terms of the times saved in doing the hand hygiene. So it has got a practical edge over the gold standard. So perceiving the benefits of increased efficiency and cost saving, this could be a method that can be used in practice. The next is the use of beta hydroxy beta methyl butyrate supplementation in multi-trauma patients. It's a single center parallel group blinded placebo controlled trial with 50 multi-trauma patients. Here the intervention was daily administration of either the 3 grams of the drug or placebo for 28 days until hospital discharge. The primary outcome being the feasibility of administering the supplement and the protocol adherence. Secondary outcome were muscle mass, muscle strength, physical function, and quality of life. Now, in this, what was found was there was 84.3% adherence to the protocol. The muscle mass outcome showed slightly favorable towards less reduction in muscle mass in the intervention group, but with considerable uncertainty. And the nutritional delivery was comparable, energy and protein delivery was done in both the groups. So in conclusion, administering the drug in ICU for 28 days is feasible, and the uncertainty on its effect on the muscle mass does remain. The next is the management of post-stroke hyperglycemia, that is the TECASIS trial. It is a phase 2 international prospective randomized open label blinded endpoint trial. In this, adults with acute ischemic stroke, that is less than 90 hours from onset, with blood glucose more than 4 millimoles per liter and pre-stroke modified Rankin of less than 2, they received exenatide versus standard care for 5 days or until hospital discharge. The proportion of patients with more than 8-point improvement in the NIHS score or achieving NIHS of 0 to 1 at 7 days post-stroke. The result was 350 patients were randomized. Primary outcome was achieved in 61.2% in the exenatide group and 56.7% in the standard group. So exenatide did not significantly reduce neurological impairment at 7 days, but significantly reduced hyperglycemia events without causing any episodes of hypoglycemia. So it is safe to use it in larger trials to get more conclusive evidence. And no episodes of hypoglycemia or serious hyperglycemia were noted. Nausea and vomiting occurred in 3.5% of exenatide patients who were mild and short-lived. The next is the conservative versus liberal oxygen targets in children. This was a study done in 15 pediatric ICUs in the UK, where children less than 18 years were included. The intervention was to keep a conservative target of 88 to 92%. And in this, the results provide that conservative target decreased the mean saturation and oxygen exposure, indicating a potential benefit. And there were no other complications due to the lower oxygen usage. So the next is the use of haloperidol to reduce delirium burden in critically ill patients. It was a multicentric RCT which was done in the Dutch ICUs, that is a mixed medical and surgical ICU in critically ill patients. In this, they gave haloperidol 2.5 milligrams or placebo every 8 hourly, titrated to 5 grams every 8 hourly if delirium persisted until ICU discharge or up to 14 days. Primary outcome was ICU delirium or organ or coma-free days within 14 days after randomization. The use of sedatives for agitation, patients' initiative for extubation, invasive device removal were secondary outcomes. So the trial was terminated early due to primary endpoint futility after 132 patients, that is 65 in haloperidol and 67 in placebo group. Haloperidol did not reduce anything in terms of the primary outcome. So haloperidol does not reduce delirium in critically ill patients, but may reduce the rescue medication requirement and agitation events. These parameters can be evaluated further in other trials. The next is the use of safety and efficacy of the newer drug, that is generic ramifentanil, in Japanese ICUs. It was a multicentric RCT in a non-inferiority phase 3 trial with adult patients in mixed ICU. The patients were randomly assigned to receive either ramifentanil or fentanyl, and the dose was titrated until the targeted level of analgesia was achieved. Now, the proportion of patients who did not require rescue fentanyl was the primary outcome. In this, 100% of the remifentanil group and 97.8% of fentanyl group achieved the primary endpoint, showing the non-inferiority of ramifentanil to fentanyl. And it was quite safe with almost similar side effects. So ramifentanil can be used for safe pain management in mechanically ventilated Japanese ICUs. Next is the effect of an online information tool on PTSD in relatives to ICU patients. It was a double-blind randomized placebo-controlled trial where 89 family members of critically ill patients were included, and in this the intervention was they were given intervention website where they were given information about the patients, and a control website where not much information was given. Now its effect, that is impact on the event scale score to assess the PTSD symptoms, and other parameters like hospital anxiety and depression scores were also noted. This showed no significant difference in the PTSD symptoms between the intervention and the control group. So online information on critical illness did not reduce the PTSD symptoms in family members of the ICU. The family members of the ICU often have significant PTSDs, highlighting the need for finding out some more effective support mechanisms so that we reduce the burden in the relatives. Next is standardized family participation program in ICU. It is a multi-centered stepped wedge cluster randomized trial of 7 adult ICUs in general and university hospitals. It included 306 relatives, 235 ICU healthcare providers, and standardized program facilitating family participation in essential care was the intervention. And the main outcomes were anxiety, depression, and PTSD. In this, they found no significant difference in the anxiety, depression, or PTSD among relatives in which the intervention or control period. Slight decrease in reported satisfaction in the intervention periods were noted. Now, the healthcare professional perspective is increased knowledge and skill among relatives to participate in ICU care during the intervention period. The conclusion by the program did not change the mental health symptoms, it changed the clarity, knowledge, and skill among the relatives and the ICU healthcare providers regarding the family participation in the ICU care. The next is mechanical ventilation mode type on the post-operative outcome in cardiac surgery. It is a single center prospective RCT. In this, 1,367 adults underwent cardiac surgery with bypass. They were randomly assigned to one of the 3 ventilation strategies, VCV, PCV, or pressure controlled ventilation volume guaranteed, or the PRVC mode. And the primary outcome was post-op pulmonary complications. The PPCs occurred in similar proportion across the groups. There was no significant difference, and the type of intraoperative ventilation did not impact the outcomes. Next is baricitinib or the ravulizumab in adults with severe COVID-19. It's a phase 4 RCT in adults patients with 22 UK hospitals with risk score of 40% risk of ICU admission or death. Now, the intervention was randomly assigned to standard care alone or to give baricitinib or the ruvalizumab. The primary outcome was the first event to death, invasive mechanical ventilation or ECMO support. Out of the 417 patients who were randomized, the trials were stopped early because of the futility. The hazard ratio of reaching the primary outcome was 1.11 for baricitinib and 1.53 for ravulizumab, comparing to the standard of care. So neither of the therapy were found to be of any benefit in severe patients. The next is the extracorporeal life support in cardiac arrest, the INCEPTION trial. It's a multicentric RCT where patients with refractory out of the hospital cardiac arrest were included. They were randomized to extracorporeal cardiopulmonary resuscitation or the conventional resuscitation. And the survival at 30 days and 6 months was noted. The Bayesian reanalysis estimated as 42% probability of a minimal clinical important difference between the eCPR versus the conventional CPR. So no statistical significant treatment effect of the primary outcome in the frequentist approach. The Bayesian approach provides a probabilistic interpretation of the results, suggesting a potential but uncertain benefit, which means that we can say that if we are using eCPR, then there is a 42% probability that there can be some kind of a minimal clinical difference compared to conventional CPR. Now, this is the one lung ventilation versus post-operative pulmonary complication with major lung resection. This was a single-centered RCT. This was a multi-center randomized single-blind control trial with 16 Italian hospitals. 880 patients underwent elective major lung resection and randomization to lower tidal volumes, that is 4 ml per kg, or higher tidal volume, that is 6 ml per kg, no PEEP, no ARMs. Incidence of in-hospital ARDS, secondary outcomes were noted. Now, in this, ARDS occurred in 0.7% in the low tidal volume, 0.2% in the high tidal volume. PPCs occurred 28% in the low tidal, 38% in high tidal. Now, the incidents were more or less comparable. So, low incidence of ARDS and comparable post-op complication in the strategies shows there is not much difference between the two strategies. Now, passive movement to prevent or reduce joint stiffness in medium to long stay ICU patients. This is a randomized control within participant assessor blinded study. It is a 40-bedded tertiary care adult ICU. Intubated patients expected to be on ventilator for more than 48 hours were included. And here the intervention was passive movements applied to the ankle and the elbow on one side of the body twice daily for 5 weeks up to 4 weeks. The other side of the body acted as the control. And the primary outcome was ankle dorsiflexion range of motion at cessation of the passive movements. And they found no significant clinically meaningful effect in the parameters. The next is fibrinogen concentrate versus crab respirator in cardiac surgery. Is a single center prospective RCT in Kazakhstan. They included the bypass patients who had significant bleeding risk and hypofibrinogenemia. And the intervention was the patients were randomized to receive crab precipitate or fibrinogen concentrate. Now, 88 patients who acquired hypofibrinogenemia were randomized, and mean treatment cost was $631 per patient, which was significantly lower to crab precipitate, which was $1,500 per patient. So, crab precipitate and fibrinogen concentrate had comparable effectiveness. However, fibrinogen concentrate were easier to handle, lower cost, and had higher purity. The next is prostacyclin in trauma patients with hemorrhagic shock. It's a multicentric RCT, and 229 trauma patients with hemorrhagic shock were included. The intervention was 72 hours infusion of prostacyclin analog iloprost in 1 nanogram per kg per minute or placebo. And the primary outcome was number of ICU days alive. And the mean number of ICU days alive within 28 hours was 15.6 for the intervention group and 13.9 for the placebo group. So there was no significant difference between the populations. The next is the restrictive versus classic IV therapy in septic shock, the classic trial. In this, the study provided probabilistic interpretation and evaluated heterogeneity in treatment effects. The major findings were absolute differential mortality was 0.2%. with the restrictive fluid strategy, the positive probability of benefit was 72% for serious adverse effects, 52% for uh, life support therapies, and days alive. So the conclusion is restrictive IV fluid therapy showed a potential for benefit, but clinically important effects could not be ruled out. 97% probability of HTE was observed in previous IV fluid volumes, indicating potential lower mortality with restrictive IV fluids with previous IV fluid volumes. Safety and efficacy of glibenclamide. Safety and efficacy of the drug in acute cerebral ischemia was done. It was a prospective randomized double-blind RCT in 306 cases with adult patients, that is 18 to 74, with symptomatic anterior circulation stroke with NIHS 4 to 25, treated with intravenous RTPA within 4.5 hours. And they were randomized to 1:1 of glibenclamide or placebo. And the loading dose was 1.25 milligram and then 0.625 milligram every 8 hourly for 5 days. The primary outcome was 90-day Rankin scoring. Now, outcomes was assessed by trained neurologist and the assessment was modified ranking, and good outcome at 90 days in both the group was comparable. The next is study on appendicular perforation and perioperative delay. It was a pragmatic open label non-inferiority design with Finland hospitals, adult patients, randomized 1:1 appendectomy, and the primary outcome was rate of perforated appendix diagnosed during surgery. And in this 2095 were assessed, 1822 were enrolled, and the outcome was the perforated appendicitis rates were similar between the two groups, and there was no significant difference in the 30-day complications. So the conclusion is no increase in the risk of appendicular perforation or complication is noted with longer in-hospital delay, that is up to 24 hours. The next is Adam-Gamadex versus Sugamadex. It is for the rocuronium reversal. It's a multicentric RCT, 310 patients. And this looked at the efficacy, 98.7% efficacy in the Adam-Gamadex group and 100% in the Sugamadex group, which was achieved with the train of 4 ratio. The secondary outcome was mean time to recovery of the ratio of 0.9 to 2.25 minutes for Adam-Gamadex and 1.75 minutes for Sugamadex. So there was no significant inferiority in the secondary outcomes as well. So Adam-Gamadex had lower incidence of adverse effects compared to Sugamadex, including anaphylactic reactions and recurrentizations. Citrate anticoagulation or no anticoagulation in CKRT. This is a RCT where the randomization was to receive regional citration versus no anticoagulation. And in this, they found a significant higher in the filter failure rates in the no anticoagulation group. Cumulative incidence was more in the no anticoagulation group. Side effects because of citrate were okay, not too much, and no significant increase in the regional citrate anticoagulation even after 6 were noted. The next is the prone positioning in ECMO. It's a RCT in severe ARDS patients done in France, and the ECMO weaning was 44% success was seen in both prone and supine within the 60 days. No significant difference in ECMO durations. So no adverse effects either of proning. So prone position did not significantly reduce the time to weaning, nor there was much complication associated with it. Now, airway management of comatose patients with acute poisoning. Now, in this, they included patients who were comatose, came with acute poisoning at a multicentric RCT with GCS score less than 9 in French ICUs, and they found significant benefit in the intervention group for the primary outcome and lower proportion of any adverse effect in the intervention group compared to the control group. So withholding intubation in comatose patients with acute poisoning showed greater clinical benefit for in-hospital deaths, ICU stay and hospital stay with fewer adverse effects and lower pneumonia incidence. The next is intravenous levothyroxine for unstable brain dead heart donors. And in this, this was an open label RCT. This was done in hemodynamically unstable potential heart donors after brain death. Now, patients were randomized to receive IV levothyroxine or saline placebos. And heart transplantation, 54.9% in the levothyroxine group and 53.2% in the saline group were achieved. Graft survival was similar in both the groups and no significant differences. So intravenous levothyroxine did not significantly increase the number of heart transplanted compared to normal saline infusion. The early unload, that is unloading of the left ventricle in ECMO, this was the RCT in 116 cardiogenic shock patients done in South Korea. The intervention was randomly assigning to early routine left ventricular unloading by transseptal left atrial cannulation or the conventional approach with rescue cannulation. Now, all cause of mortality at day 30 were noted. Mortality was 46.6 in early unloading, 44.8 in the conventional. Crossover 50% in the conventional underwent rescue transseptal left atrial cannulation, and secondary outcome were no significant difference. So early routine left ventricular unloading did not reduce the mortality. Intrapulmonary percussive ventilation in critically ill patients. This is aimed to removing the circulation and reducing the ICU stay. 106 non-ventilated patients and chest physiotherapy, and compared with chest physiotherapy, the length of stay was shorter in the IPV group compared to the chest physiotherapy group, and similar improvements were noted in radiological atelectasis score. No adverse effects were noted, and the percussive ventilation resulted in shorter hospital stays on the ICU stays with the improvement in pulmonary complications. The next is transfusion strategy in myocardial infarction and anemia trial. This looked at the transfusion triggers in myocardial infarction. That is 3,500 patients were included, and they had two cutoffs, that is 7 to 8 versus 10. And more transfusion were done in the liberal group. Similar occurrence rates in both group in the primary death events. Similar higher rates in restrictive, but no statistically significant difference. So a liberal strategy did not significantly reduce the recurrent myocardial infarction or death at 30 days compared to restrictive strategy. So in myocardial infarction also, you can safely go with strategies of 7 to 8. The next is the rifaximin in hepatic encephalopathy. This was the objective was to see how it acts on cirrhotic patients. They included 184 cirrhotic patients, and one group was giving rifaximin, the other received only antibiotics. Now, the primary objective that was similar in both the groups, that the primary objective being resolution of the hepatic encephalopathy. Now, time to resolution and in-hospital mortality, no significant difference. Nosocomial infection were comparable. Subgroup analysis, rifaximin led to lower in-hospital mortality in patients with decompensated cirrhosis, but not in acute and chronic liver failure. So rifaximin addition to antibiotics did not significantly alter outcomes or mortality, but benefit can be noted in the subgroup of decompensated cirrhotic patients. The next is magnesium sulfate in TTP. The 72 adult patients were included. The magnesium sulfate 6 grams IV followed by continuous infusion for 3 days were given, and they looked at platelet normalization. Median time was 4 days in both groups, so similar. No special effect of magnesium in improving platelet function in TTP. The next is aspirin hemocompatibility events with left ventricular assist devices. They included adult patients who were on left ventricular adult device, and one group received aspirin, the other antithrombotic regimen. And they looked for survival free of major non-surgical hemocompatibility adverse effects at 12 days. Higher event-free survival was noted with aspirin, and non-inferiority to placebo was demonstrated. Reduced non-surgical bleeding in placebo group, no increase in stroke or thromboembolic events. Avoiding aspirin in patients with advanced heart failure treated with fully magnetically levitating LVADs is not inferior to a regimen containing aspirin and does not increase the thromboembolism risk or is associated with any bleeding complications. Thank you for your patience, and subscribe to our channel and click the bell icon if you want to receive similar videos in the future. Thank you.